Hello everyone. On behalf of ANROWS and MAVE, the Melbourne Research Alliance to End Violence Against Women and Their Children, I would like to welcome you to today's webinar, Violence Against Women and Mental Health. My name is Michele Robinson and I'm the Director of Evidence to Action at ANROWS, Australia's national research organisation for women's safety. I acknowledge the traditional owners of the land across Australia on which we meet today, and on behalf of ANROWS, pay respect to elders past, present and emerging. Wherever we are today, we are on unceded Aboriginal and Torres Strait Islander land, and I acknowledge and pay respect to the Aboriginal and Torres Strait Islander people here on the webinar today. Today's webinar is a panel discussion, as per usual course, and will be followed by a live Q&A. So please send through your questions at any time during the course of the discussion, and we will try and get through as many as we can. I'd like to just confirm or to announce that it is a confronting topic today and some participants may find it distressing. It's important that you take care of yourself while watching and listening. If you'd like to access support, please contact 1800-RESPECT, the number on the screen, or Lifeline. Similarly, the number is up on the screen. Mental health intersects with domestic and family violence in complex ways. Mental ill health can be a compounding factor, a barrier to victims and survivors accessing support, and can also be used as a tool against women by perpetrators of domestic and family violence. I'd like to acknowledge and honour the victims and survivors of domestic and family violence. And I would also at this point like to acknowledge that there are women for whom the impact of gendered violence and mental health is great, far greater than some others, including Aboriginal and Torres Strait Islander women, culturally and linguistically diverse women, LGBTQ and women with disability. Today's discussion is only an hour and we won't have time to discuss these issues in detail. The impacts for these women are great and are all deserving of webinars separate to this. Today's webinar will draw on the evidence base and focus on how health systems at the policy and practice level can better address mental health and violence against women. Now to our panel. I'd like to introduce you to Professor Kelsey Hegarty from the Centre for Family Violence Prevention, Royal Women's Hospital and University of Melbourne. Carmel O'Brien, OAM, Counselling Psychologist with PsychRespect in Victoria. Fiona, a representative with lived experience and member of the Weavers panel at the University of Melbourne. And Dr. Sabine Furbacher, an independent consultant with policy and practice experience. Okay, so let's head into the discussion. Kelsey, let's start with you. Kelsey Hegarty is an academic general practitioner and leads the Safer Families Centre of Research Excellence. Kelsey also chairs the Melbourne Research Alliance to End Violence Against Women and Their Children, known as MAVE, with whom we're collaborating today. Kelsey, you've been looking at models of care and health system support for survivors of domestic and family violence, including health practitioner readiness and women-centred care, for some time now. What are the main elements of your recent work, the care and catch models that we're going to look at today?
Thanks for asking, Michelle, and it's such a pleasure to be here, and I would like to just acknowledge all the survivors in the audience again, and say that when we're talking about mental health, it's really a trauma response, isn't it, to a social entrapment. So really, we've been carefully at MAVE and at Safer Families Centre listening to the voices of survivors and practitioners. And one way to do that is to think about if we collect all the interview and focus group studies globally and try and look at what are women trying to tell us who are survivors from what they want in the health system and what are practitioners wanting to tell us as well. So could I have I've just got 3 slides here. So Rachel, could I have the first one? Because Laura Tarzia led the work around what expectations and experiences for women are for health providers and mental health providers included. Now, this is familiar to some of you, I imagine. It's the World Health Organization first line response. And it sounds simple, doesn't it? You know, if we listen to the person closely with empathy and without judging, if we inquire about her needs and respond to those, if we validate a person's experience and assure them that they're not to blame, if we try and work with them to enhance their safety, discussing a plan to protect herself from the impact and harms of violence, and if we offer support. And I know this sounds simple, but this is what women are still crying out for. So this is the what, and that was found in these studies, in the meta-synthesis that Laura Tarzia led. If I could have the next slide now. So complementary to that is the how. So these aspects will be familiar to those of you who understand the principles of trauma-informed care, which have a longer set of principles. But what we found, and there was a large group of us involved, was that women particularly wanted choice and control in what the health practitioner and the health service was assisting them with. They also wanted help with action and advocacy. So not just simply to sit and listen, although that is really, really important, but to actually assist people, to be an advocate or an ally for them. And then to really recognise and understand that underlying their health issues, their mental health issues, is this fundamental abuse and violence. And then finally, the emotional connection. And this is almost, how to be kind. It's the connection that can happen between a health practitioner and a patient or a woman or a client. So this care model is really important to women, and they were mostly women that were in these studies. So really that how is here and the what was before. And although that sounds simple compared to mental health treatment and diagnoses, these fundamental blocks are sometimes missing in the health system response. So then if we move to practitioners, because myself and the next slide, myself and Gemma McKibben led another meta-synthesis, and this one looks a bit more complicated, but I'll take you through it. So this is the catch model, which is, we didn't ask. We looked at the studies to look at what the enablers were, or the things that made practitioners ready to do this work. Because we know not all practitioners are trained in this or good at this or doing this work. We know that for sure, even in the mental health sector, we know that. So the catch model is, and I'll take you through the circles in the middle first. So the first one is commitment, and it's about having a commitment. Now that commitment might be from a feminist, a child's rights, a human rights, and it might be their own personal experience. And that overcomes the other barrier that, this isn't something the health practitioner should do. I can't take responsibility because this isn't the work. But if you have a commitment, then from those things, you're more likely to be ready. Similarly, if you actually adopt the lives approach, the advocacy approach, and find it works, you get over the I can't control it or the frustration and anger barrier when women don't leave, or you think you know best, or inadequacy when you can't fix it. But once you try that, you get good feedback. And you've got to trust the relationship. You've got to trust that that personal relationship is the best place. Cultural understandings of, women's role and intimate partner violence as private are prevalent, those barriers, but if you trust that the health system is a good place to do this work. Now, the other two parts, the final C and H, collaboration and health system support, we're going to be going into later on, but they're really, really important. And if you have low health system support, it wouldn't matter how much commitment or how much training or how much you listen to people, it just would not work. you know, because you need to be supported yourself. Yeah, so that really, we can stop sharing. So those tips again sound simple, but if we got those things right, if the way that we do it and what we do, and if we actually act on those aspects to make, you know, enable practitioners to be ready, we'd have a much better system.
Thanks, Kelsey. I think that's been really useful in terms of walking us through the what and the how, and then unpacking the catch model. And I'd like to now turn to you, Fiona. Fiona, you have lived experience, and you're a lived experience expert, an advocate, and part of the Weavers panel at the University of Melbourne. Can you tell us your experience of accessing support as a survivor of domestic and family violence, and how you would like services to respond?
Yes, thank you for giving me the honour and the privilege of talking today. It's very exciting. I'd just like to do a little background before I start talking about my experiences, just so people know where I'm coming from. So I've got a lived experience of coercive control for about 28 years, and I ran away 8 years ago with what I could pack in the back of my car. I nursed my mother with breast cancer, and I nursed my dad with lung cancer. I lived in 9 people's houses in 4 weeks. It's never as simple as just leaving. I didn't work outside my house. My kids all went to private schools, and I was monitored from the minute I got up till the minute I went to bed. He read my emails, my texts. If we had phone calls, he would be in the background, and he controlled all the finances, and it just went on and on. So as a survivor, I think the most important thing is to be listened to. But we all think we listen, but I'd like to give some examples of when people didn't listen. Accessing a doctor where I explained my history, and they said, oh, well, you know, you'll never get well from that. Accessing a doctor about medication I was taking at the time, and they said it didn't really matter if I'd gained 15 kilos on weight because I was skinny and it wouldn't really matter. Accessing a mental health facility where I live, and them saying, look, you know, we'll help you, that's fine. And I was understandably very ill, because that's why I went to the service, and got rung a week later, and they said, oh, it's really simple. You just go onto NDIS and go on the computer and you can get NDIS. Even quite recently, talking to a doctor about, you know, like I've got some issues with energy levels at the moment. I'm just not doing that well. And I'm saying, look, you really need to think differently. If you just thought that you could get up off that couch, you could. And they said, do you understand? And I said, perfectly well. And I went out of the surgery and I haven't been back since. So seeking help can be the most petrifying thing you can do on a level that the average person has no understanding of. Firstly, when you go there, can you trust them? Will they tell your partner? Will they believe you? I mean, I was so brainwashed, I thought no one would ever believe me. Things around, you know, telling very, very private content and details about your personal life to a complete stranger. I remember the feeling when I did speak to someone about my experience who said, yes, I actually believe you and I understand you. It was huge. You know, I know that sometimes staff, particularly, you know, your general GP, they might not feel qualified to talk on domestic violence, but I would rather have someone who, when I went into that office, said, look, I don't know. That's just being a human being. But if they go away and they say, look, I'll find out stuff for you, I'll go and ring up now, come back tomorrow, I want you to come make another appointment tomorrow, that shows empathy and caring that although they don't know, they're willing to prioritise you to get information for you. Living in a small community is often very difficult, and I do live in a very small community, so for me accessing services is even harder. I don't think it's about trying to fix things, but walking the journey with the woman, seen as a partnership, helping her to make the decision. And most importantly, asking her, what are your needs? What does she want? How are you today? And the patience, because this could be an incredibly slow journey. Maybe her first realisation that she's in one of these kind of relationships. And I remember when I finally realised after reading a website that I was in one of these kind of relationships. And I just thought, oh my God, I'm just so dumb. And why can't I leave? And why was I so gutless? Because I couldn't leave. So as we all know, domestic violence is not about the suburb you live in or what car you drive, or how much money you earn, or that nice guy. It's about power and control. So never underestimate the impact that you can have for a woman seeking help. You can make a huge impact on her life. You may be the first person who's ever listened to her. It does take an amazing amount of courage to talk about these sort of things. So for someone who now has mental health issues, and I now have PTSD, what sort of things do I want? When I go to a service, how do I want them to talk to me? Well, I just want to be listened to. I want to be validated. I want to be understood.
Thanks, Fiona. Thank you for sharing your experience, and it speaks so closely to the outcomes of the research and the model that you have spoken about, Kelsey, just in terms of that commitment to listening and to seeking information and in a non-judgmental way. Thank you, Fiona. And now I'd like to move to you, Carmel. You're a counselling psychologist and you have a special interest, a clinical interest in the recovery of women and children from domestic and family violence, and you've worked across a variety of community settings. So it's really interesting to hear from you, Fiona, that you had come from a very small community. Carmel, in your experience, what are some of the barriers or challenges to responding to domestic and family violence within the mental health system? Picking up on some of the aspects that Fiona has articulated in terms of what she wanted from a service, or what she would like services, or how she would like services to respond. What do you think some of the particular challenges have been in your career?
Okay, thank you. And like everyone else, it is lovely to be with you all today. Thanks particularly, Fiona, those examples are absolute gold, I think, for practitioners. Intimate partner violence and other family violence certainly leads to psychological distress. It's a matter of degree, but we know that people who've experienced that have higher risk for depression, for anxiety, certainly for post-traumatic stress disorder, but also for other things such as alcohol and drug dependence and phobias and suicide. In fact, women who've lived with family violence have psychological distress similar to hostage victims. Some of the common dilemmas for practitioners include women not trusting the practitioner or not trusting the system beyond the practitioner if they disclose, or even knowing or believing that disclosure is going to compromise her safety. Also, for practitioners, a woman who remains in a situation that the practitioner thinks is unsafe can be a dilemma. And sometimes that can cause a practitioner or a practice to, or a service to judge a victim, to judge the woman, or even to minimise the severity of the risk. Sometimes there's a temptation to put some effort into persuading the victim to change their behaviour. And even though that's usually suggested in order to increase their safety, there's actually an inherent fallacy in that, because it's simply not the case that changing the victim's behaviour is going to reduce the risk of harm or change a perpetrator's behaviour. Another challenge is comorbidity or pre-existing conditions and diagnoses, because they can not only complicate a presentation and intervention, but they distract often from the issue of the perpetrator's damaging behaviour. Concerns about safety are an ongoing dilemma and a common theme in working with family violence. There are issues with diagnosis. So a diagnosis can sometimes help explain to a woman the pattern that's associated with her distress, and it can be useful, sometimes liberating for women, so long as the distress is seen as an understandable reaction to what is happening to her. In fact, in most cases, normalising the distress as a trauma response is part of both understanding and also of healing. However, a diagnosis can also sometimes be a tool in dismissing concerns if you're locating the pathology in the victim. So sometimes, unfortunately, that can lead to concerns about perpetrator behaviour being diluted, and therefore concerns about risk or an understanding of the risk can be diluted. And sometimes even it can lead to a perpetrator's behaviour being excused because his partner has this diagnosis. That comes under the heading of what I call "what's a man to do" syndrome. Very dangerous. It can be tempting for practitioners to give advice because of the practitioner's anxiety about a situation, and we have to monitor our own responses. That's counterproductive almost always. It's much better to let the woman know that she's believed, to acknowledge the situation, to help her assess risks and what are her best steps, but particularly to express faith in her judgment to make good decisions for herself. And people who receive good support do make good decisions for themselves, but it's their timeline and not ours. There are some wider systemic issues. Certainly female victims are more likely to end up with a mental health diagnosis than male perpetrators in family violence, and that's a whole other interesting area. Also, a diagnosis can sometimes be used as an emotional weapon, sometimes by a perpetrator, but sometimes even by a health service. Perpetrators can excuse their abuse because they point to their inadequate partner, their mad partner, or use it to demonstrate or claim that the person is an inadequate, the woman is an inadequate mother. One of the other systemic issues is that labels tend to stick, and often they follow people round in their files as if women don't recover from this. It's amazing how well people do recover when they're no longer being routinely harassed and assaulted. One of the other issues that I've certainly noticed running family violence programs is that the counselling files of women and children who've been victims of family violence are still being subpoenaed for court hearings, particularly family court hearings, and can then be used as a weapon in court. So not only does that have quite destructive ramifications for survivors, but it also makes many women less likely to seek appropriate support for themselves and their children. Now, just in relation to COVID, family violence, particularly intimate partner violence, is characterised by social isolation and by coercive control to direct or limit people's behaviours. And unfortunately, those are exactly the tools that the nation has used to keep most of us safe from the pandemic. So it is no surprise to us, to me, that family violence rates have risen across the world during the pandemic. Women are more likely to be spending long periods of time with a perpetrator. They're more likely to have reduced access to formal supports, but also to informal supports, such as their own families, their peers, their school and their work communities. And the other life stresses that contribute to risk are also on the rise. So that would include things like housing stress and poverty and unemployment. Telehealth can make it more difficult, can be more challenging to try to assess risk, and also more difficult for those who need support to access this kind of confidential support in their own home through a telehealth service. So there's some of the dilemmas, and I'm sure that all of you could come up with more.
Thanks, Carmel. It's really, yeah, that's a great setting out the practitioners. What really struck me in listening to you was, and thinking about the catch model, Kelsey, the breadth of who the practitioners are, and practitioner readiness is, who were you looking at in the development of your model? I'm just going to throw to you quickly, because from what Carmel has said, it's expansive. Yeah.
It was a whole range of practitioners, from GPs and primary care nurses and antenatal care nurses and maternal and child health people and mental health practitioners. So a large variety the studies were in. So I think that different particular readiness might happen in a particular group, but these were the ones that tended to be across the practitioners.
And again, we hear, sort of the resounding and resonating comments of both Fiona, Kelsey and Carmel in terms of acknowledgement non-judgment, or decision making or assistance with decision making, and I guess the support aspects that do seem really easy when we talk about them and when we present models, but obviously they're the ones that keep coming up in terms of hindering any resolution. So Sabine, this is where you come in. So you have Dr. Sabine Furbacher. You work as an independent consultant now, but you have worked across policy areas including family violence, sexual assault, homelessness, and mental health, and the intersection of these. And they're regularly and intersecting, as we've been discussing. Sabine, what are the policy responses required to address the issues that we've been discussing? And given your experience in policy and practice design, what advice and examples can you share in this response?
Thanks, Michelle. And like everyone else, I'm really glad and happy to be here, and thanks for having me in this webinar. So as we just kind of were reminded by all three previous speakers, in particular by Fiona, policy, I think, has to absolutely always start with lived experience. We need to listen to survivor voices, their experiences, and that needs to be always the starting point. Aided by research and practice knowledge, of course, as well, it needs to ultimately focus again at the end on lived experience. And what I would think, what we always need to think about is once we develop a policy or have a policy, we need to be doing better than what we did before, whatever that before looked like. Policymakers really need to ask the question of how can policy support systems, organisations and individuals to do their best in recognising and responding appropriately to family violence, in this case to women who experience family violence and experience mental health issues or challenges or within any of those kind of systems. As Kelsey will talk a little bit more, also there is a need, of course, for education for people working in mental health services in the primary care sector. So if there's a willingness and a readiness, people also need those very, what we were just saying, it sounds like really simple skills, but people still struggle with those. And I'll come back to that a little bit later, some ideas around that. The better they feel equipped and the more confident they feel, the better they will be at working with women who experience family violence and respond appropriately and supportively and know how to engage and know how to be with and hold that space, as Fiona was describing before. Equally, of course, they need to be supported by their organisation, as also was touched on, which in turn needs to be supported by policy, by good, usually state government or national policy. Mental health services, as we know, and many practitioners in it still do not necessarily identify family violence, or they might not feel responsible for responding to family violence. They might think that's someone else's responsibility, but not there. They might also, as Carmel was pointing out, misunderstand or indeed pathologise women's distress. Women's distress or a trauma reaction to something that they've experienced, trauma they've experienced, and what we know now within the trauma-informed care kind of practice, a normal response. It's not. It's a normal response to distress, to feel a whole range of things and how that manifests. We of course know, and as Carmel was talking about, that there can be many long-term effects of trauma on women's mental health. We also know that women with an already diagnosed mental illness who may have been involved with mental health services or practitioners for a long time or a shorter time experience high rates of family violence, and that again will exacerbate their mental health challenges. Policy, I think, can provide guidance about women's reactions being understood as a reaction to the trauma they have experienced, and policy has a real responsibility in redirecting certain sectors who are a little bit more behind or are just coming to the realisation of that. Policy, of course, needs to be high level, but in step with current research. It needs to be practical enough to be useful. It needs to be written in a way that assists implementation. Again, that seems so simple, but we know that doesn't always happen. It needs to it needs to be really clear about the responsibilities for organisations, for organisational leaders, and for practitioners. So it needs to address all those levels, I think. I don't just think that, I've done some research in it and worked in it as well, but that's kind of what I've come to. Strategies for implementation can really go a long way. Assistance, including associated funding or resources of other kind, of course, help too, and help enormously at times. This goes for state government policy, or for policy for professional peaks. So, for example, those responsible to direct GPs, psychiatrists, or allied health professionals, all of those peaks or associations who work for people who work both in primary care and including mental health, or in tertiary or clinical mental health sector. Organisational and cultural change that challenges previously held ideas, I think, must be part of policy implementation. For example, moving away from a pathologising of women's distress, or assuming that's not my role, that's a family violence services role. It is my role if I work in mental health, or as a GP, or as a private practitioner. We do know, sadly, that research takes approximately 15 years. There's been research on that to be translated into practice in health services in other sectors. And we know that many policies get published, hardly ever get read, or sometimes get read and never get implemented. So we don't want that. I think hopefully nobody wants that, but we know that that's the reality, or has been the reality at times. So I wanted to provide some examples from the Victorian experience from a number of us. So following the Royal Commission, which of course has been a huge impetus and for change, and you know, Victoria is experiencing a so-called catchphrase, unprecedented change in family violence. The design of the new approach to family violence in Victoria is broad-reaching and has a strong focus on implementation, and that's, I think, is one of the really big shifts in Victoria, that there is that focus by state government on implementation. It includes education for leaders, for managers and practitioners. It includes tools for implementation for organisational leaders and managers, such as how do you align current policy with your organisational policy? How do you go through all of the things that you need to do to actually adjust and now really come in line with state government policy? It includes practice guidelines for practitioners, including clarifying roles and responsibilities, and it's been made very clear through government policy that it is, in this case, mental health practitioners' responsibility to engage, support, identify family violence and work with and support people. So that is very clear now. There's a rollout of a really massive statewide training strategy, and not just this training strategy, people are actually being trained, and I know firsthand about that because I'm one of the people who has delivered and continues to deliver this training this year as well. Mental health clinicians, mental health practitioners are part of that training rollout. They actually don't have a choice, they have to participate. Their organisations are mandated to not only align their policy, but they're also mandated that all mental health clinicians have to attend this training. And it was meant to finish last year, it kind of finished, but it's just being picked up again because not everyone had been trained yet. So thousands of people are being trained as beyond mental health, of course, but AOD, mental homelessness services, maternal child health nurses, etc. But just focusing on mental health, they have to. I'm not saying this system at the moment and the policies are perfect, nothing ever is, I think, but it's a really good attempt at also focusing on implementation and bringing those different elements together, policy, training, organisational work, and really implementing the changing and managing that. Part of the implementation of the Royal Commission into family violence in Victoria, one of the recommendations was required the publication of a guideline on family violence by the chief psychiatrist, who kind of, is responsible for all kind of clinical mental health services. And I had the good fortune to work with the chief psychiatrist in developing this document, and we took the opportunity to go a bit beyond just a policy document, which can be 2-3 pages maybe. We decided to develop a guideline, so a policy guideline, but also a practice resource, because we wanted to bring in that more practical, part of it to make not sure, we can never be sure, but to assist and aid implementation. We wanted the document to not just sit on a shelf, read by a few managers, if that at all. So the document outlines organisational responsibilities, tips for implementation, strategies for practice and connection to the broader developments. Another Royal Commission recommendation saw the establishment of family violence advisors in mental health services and AID services, and a number of those have actually gone through that training that I'm part of delivering. They told me about how helpful the Chief Psychiatrist Guideline and Practice Guide is in their work. The advisors are there to assist organisations, organisational leaders and practitioners in their work around all things family violence, but they were talking about how the guideline assists their work, and if there is a bit of a rumbling and not so sure, they can actually use it to say, actually, look, this is what the Chief Psychiatrist says. This is another a document that can assist us in this work. And because the guideline includes practical tips, they can kind of pull out different elements and use them in their work, and the organisations can as well. In that way, the guideline assists family violence advisors in their work, as well as clinicians and leaders in their roles. So that's just one example where high-level policy, so through the Royal Commission, seems to make a difference. There's an evaluation of it, but we hope that ultimately it makes a difference in service provision as well. So the round off, I just wanted to say that I think policy needs to be, it's kind of a jigsaw approach. All the elements, there's a number of elements that need to come together, many parts fitting together. They include obviously policy direction and documents, but they also have to include implementation strategies and the actual implementation and monitoring that. How is that going? Are we doing what we said we will be doing? I know that, again, it's a bit like other things. It sounds so simple, but it often doesn't really occur. And it always has to also include professional development, and that needs to be ongoing. And then, of course, a review, and then we, go again in the next kind of cycle, and adapting to changes over time as well. That's me in a nutshell. Thanks, Michelle.
Thank you, Sabine. You've raised many things there. But what I did want to just check in terms of the compliance with that guideline, what sits behind that for the mental health services, like the family violence advisors? Is there anything behind it that ensures it, or has it been monitored?
Yeah, has it been monitored? So what's monitored on a high level, state level, is the implementation of all recommendations of the Royal Commission. So on that level, it is that, but that is more looking at has this policy or guideline been published. So that's kind of ticked. Yeah. I don't know actually if the mental health branch or the chief psychiatrist does check back. I imagine so. What does get monitored is that mental health clinicians attend the associated training. So that's not about the guideline, but the associated training around that's being rolled out. So one of the reasons it's been extended is because there's so many people in mental health and other sectors as well. They couldn't actually go through the training because there was more volume that could be accommodated last year. What I do know is that the chief psychiatrist currently, the guideline was actually published before some of the higher level policy documents came out, because of course they took some time. So they're actually just in the process of updating and re-looking at the chief psychiatrist guideline and looking at which changes have to be made. So I would imagine that they would use that, hopefully, as a way to check in with mental health services about their level of implementation.
Yeah, and the implementation of 15 years is a concerning number of years, isn't it? And I'm going to throw to you, Kelsey. It is my role. You've been working on research which has informed practice and organisational change in health systems. I'm thinking with search and sustain. But you've been using a model whereby you've been changing policy and practice while you've been researching. So the evidence is informing change almost directly. What have you seen in terms of the outcomes of WITH and SUSTAIN, and also out of the care and catch models?
So thanks for that, because I think, you know, Sabine, thank you. It's just so complex. If someone could just put the WITH model up, because all of us have got guidelines, all of us have got policies, all of us have got training, and we've heard a little bit about the stick in Victoria. But if we go to the WITH model, this is a project we did for ANROWS, where in fact we were looking at sexual violence and mental health services, and what are the building blocks for actually getting change, for getting that women-centred care, for getting the practitioner-centred support. Rachel, can you put up the WITH model? Yeah, thanks. And how do we get that trauma and violence informed framework? You know, how do we get that work done, and why does it happen? So these were the building blocks we found: that you had to have relationship building, you had to have integrated coordinated care, you had to have a reflective system that was feeding back to people, to practitioners, to women, which was your question, Michelle, you know, like how do we know something's working? And we have to actually have basic infrastructure of environment and workplaces. So from that WITH project, we then did a second ANROWS project called SUSTAIN, and I'm speaking a little bit quickly because I want to leave time for questions, where we went a bit further and tried to integrate what we were finding from care and more recently from CATCH, but also from WITH, the model I just showed you. And we came up with this real thing, which again is a simple one, but we don't spend enough time on the relate as to how it gets done, whether at the woman's level or the practitioner level. We don't then spend enough time on the engage. You know, they're different things for the woman and the practitioner. And we then have, you know, that trying something out, launching the guideline, doing whatever, but we have to monitor and learn from that. And the details here are on the ANROWS website, so I'm not going to go through all of them. But I'd like to finish now with the next slide, which is where once we've also done a synthesis led by Renee Fialet in our SAFE group at the University of Melbourne, where she looked at what do Indigenous peoples globally. There are only 6 studies in the world, what they want and expect in the context of family violence. And if we layer some of this over it, you know, the cultural awareness, the connecting for trust and the strengthening safety has a different lens on it, which we can learn so much more from. So I've just done that quickly, but I think these things are, we can have the existing organisational, practitioner and individual level, but we need these building blocks.
Yeah. Thanks, Kelsey. I think that's been really useful just to draw together, and those building blocks are really consistent across all 3-4 models. Thank you. In terms of, now we've got 15 minutes left and we have many questions. I think what I'm going to do now is go to questions, and Fiona, the first one is for you. And you mentioned that in your presentation, what is the impact of coercive control on women's mental and physical health?
Well, I can only speak on my own experience, and coercive control is a very insidious form of abuse because it happens very, very slowly over a long period of time, and things are presented to you by your perpetrator in a way that you may see as palatable, but they're not. And it starts very slowly and very insidiously. Like, for example, in my case, well, you don't have to work outside the home, you know, because I'm an old-fashioned guy, so you can just stay at home. So then I stayed at home. And so what happens is over long periods of time, they take on more control of everything and you do less. So as time goes on, you don't do your finances, you don't pay the bills. I was allowed out of the house to do shopping, one of the rare times I was allowed out of the house. And it would even monitor things like me going to the doctors. I could never get to the doctors. So these things happen very slowly and very insidiously. And so what happens to you as a person is for me, I felt like I just died inside. I felt my soul had died, that there was nothing left whatsoever. And I think I probably spent about 10 years of my life just keeping my head down. And I would describe it as zombieing my way through life. It had huge ramifications on my physical health and my mental health.
Thanks, Fiona. And I will open that up to the panel as well. And, you know, as you all know, coercive control and how we respond to it is a national conversation at the moment. And I think your insights and your experience, Fiona, are really important. Thank you for sharing. To Kelsey or Carmel or you, Sabine, want to make a comment on?
I'm happy to get the ball rolling. I think one thing that's interesting is that as a general community, we are making the shift from understanding domestic violence as somebody being hit to understanding domestic violence as it being a much broader social disease, social dilemma, and that coercive control actually is what does the most damage. If it was all about hitting, then the people who would be doing the healing would be mainly doctors and nurses, and people mostly would heal well. That's not what happens. What happens with coercive control with people who are living as hostages in their own home is that there are very long-term psychological ramifications of them living the way they live and losing confidence in themselves and all kinds of existential damage that takes a long time to repair. And, you know, if it was, it's coercive control really that keeps the mental health professionals involved in family violence.
Thanks, Carmel. It's really good to have that intersection outlined. Kelsey, did you have your hand up earlier? Is there anything
I just was going to say, imagine you're seeing someone and you don't know that that is happening to them and you're dealing with mental health symptoms. That's what it's like this hidden total issue in someone's life. And most most practitioners do not know that when they're treating depression or anxiety. You know, it just has to be asked about.
Sabine?
Yeah, and just quickly to add on, and even if people or practitioners know but don't understand it enough, they might still ask the question, why doesn't she leave? And we don't have to unpack it, but I just, you know, I was so struck, Fiona, by how you described it so exquisitely well about the eroding impact. And if people don't get that, they will ask that question, won't they? And then, you know, a whole lot of things can go on, you know, if she was, and then kind of also potentially go into that pathologizing or just not understanding, which then is so detrimental as well. So, yeah.
I guess it's a really good segue into the next question, which a member of the audience asked, how do we get mental health and family violence services to work more closely to support women? Kelsey,
I just click my fingers. They listen to the panel, and that's such a big question, isn't it? Because the paradigms traditionally arise, and as I said, we've done work in the sexual violence. You know, there's a very feminist paradigm, and then there's, in the olden days particularly, a more medical paradigm for psychiatrists and psychologists, and obviously social workers work in a different paradigm towards feminists. So it's really comes down to, you know, and you're familiar with this, Michelle, Nadine Watson's work of talk, time and trust. I mean, if they never speak to each other, they have no time to collaborate on people, you know, people's stories. They're both seeing the same person, but they never get time to talk to each other, and they don't trust each other. And they, you know, I've seen many examples of that where different professions don't trust each other. They're not co-located. Co-location helps, you know. We've certainly seen that at the Women's Hospital with some co-location. And they've got to actually work together, because they, at their hearts, they have patients or clients, you know, or people They all have at their hearts, most of them, they want to help people, but they see it with different lenses. So it's actually having to come together, I feel, you know, to talk and have a bit of time and learn to trust each other.
And I guess the way in which, pardon?
Simple again.
Simple. Yeah, and the structural impediments, which, as you say, co-location, funding models, a whole range of different things that keep them separate. But Carmel, you've worked across.
Yes,
Right.
I think that I think we have made some progress. The women, in my experience, who do the best and recover more quickly are ones who have what I call a circle of care, and that helps them because a single practitioner or a single service cannot do everything that someone needs usually, and it is liberating for a practitioner in a particular service to know that they don't have to do everything, that a domestic violence worker is very experienced at doing a risk assessment, that a housing worker is there to help the person with housing, etc., etc., that the GP is on board and will help monitor the medication, and that, you know, you don't have to worry as much about that. So the circle of care helps everybody, really, and I think it's about everybody, though, having the same lens. That's the difficulty, as Kelsey was saying, and that's why having people who unite for training, I think, is better. Having a mixed multidisciplinary groups who do the same training is very good. I think also that we have some barriers in terms of status in families that have affected family violence survivors, because there is no doubt that the skills in family violence services are very nuanced and very expert in areas that doctors, psychologists and psychiatrists are often not as practiced with, and we're getting on board. So breaking down those barriers as well, making sure you're not only listening to the women, but you're also listening to each other. And, you know, a multidisciplinary team works best in most situations anyway.
I have to say,
Funding models that encourage collaboration are a really good idea.
I have to say GPs do more than monitor the medication.
No, GPs do that. And,
they have to hold it all together.
We know that. But what I mean is there are aspects of what a person needs that sometimes only one profession can provide. And that that's why working in collaboration works.
Yeah. Sabine, you were going to say something?
Yeah, no, it's good to actually to kind of talk now for me. Bring all of that together. I just wanted to say, in that training that we roll out, that's being rolled out in Victoria, where I didn't get to say before, we actually, part of it is almost exactly what Kelsey was saying early on and what Fiona was raising. It's actually about engagement, sitting with, and not jumping to action and not jumping to advice and any of those. So it's some of those really you know, they seem basic, but some of those engagements kind of skills to sort of slow people down and assist them. Some of the training is rolled out in cohorts where different sectors are together, and in this case, mental health, AID, and homelessness was bundled together, and it's been really great to see deliver that training to 3 different sectors and for people to mix. And some of what you were just talking about, Carol, actually sometimes occurs, and you can see people, you know, learn from each other's expertise. The other thing, just to add on, I know you can't quite just prescribe it, but it is actually prescribed that people from different organisations and sectors have to collaborate through what's happening in Victoria, and very clear, I suppose, boundaries, but at the same time of their responsibilities, where it starts and ends, and when you would consult and collaborate with a specialist family violence sector or service. So in that way, I think policy can assist that. Of course, it's always in the how it's being done, and also, you know, that people actually do it. But that's kind of written into policy, which is important, I think. And
one of, you know, well, 2 of the biggest barriers there are language and also information sharing. So we do have a question on that, and on this topic of collaborative care between services. One of the difficulties is information sharing. There are generally many services involved with one individual. How can this be made easier for family and domestic violence services and mental health? So I don't know if you've touched on the information sharing aspect, but it does seem to be, it's coming up a lot in the chat.
Can I say something to that? But only from a Victorian perspective, really, and of course, information sharing, because it's part of laws and legal practices in the different states, will be different in different states. So, I don't want to go on and on about Victoria, but that's my experience. So, as part of this massive change, there's been huge changes being made to information sharing and what can be shared and who can share it. So it's legislated now, as is many other things, and there's an entity now that collects certain information that different types of organisations and sectors can tap into. It's been made really clear, and that includes mental health services in any kind of sector. So I think that is a really absolutely, and having worked in mental health services for a long time, I know there's great challenges around mental health services often not sharing information, or other sectors with each other as well. But I think that's a really large piece of work that was being undertaken, and that really needs to happen on a state government level to then filter down and be introduced.
Okay, Kelsey.
Oh, just fundamental to information sharing has to be the woman at the centre of it, and I know Sabine,
absolutely.
And the biggest issue for most doctors and nurses is mandatory reporting and child abuse, and actually sometimes having to go against that instinct of seeking permission, to share information, that you have to share the information because it's mandatory to do child protection. So I think it's like a whole, big discussion around it.
One of the issues, and all of the questions are raising those big issues. I think we might want time for one more, and this is about minimum standards. How can we gain minimum standards for family and domestic violence abuse training, including partnering with victim survivors and engaging with perpetrators for allied health professionals, not only state but nationally, with Australian Health Practitioner Regulation Agency, APRA, or Australian Association of Social Work? Who'd like to wrap up?
I have campaigned that we have a basic requirement, the same as CPR. So that's the only requirement that I know of in APRA that is for doctors, is that they have to learn how to save someone's life. I'm saying that for this, they have to have adult and child safeguarding training. It hasn't got me anywhere, but I do think that it should be a basic requirement for everybody to understand this issue. And so everybody help me campaign.
I'd like to see it as basic in my profession as well, Kelsey.
Yeah.
Sabine?
Would you like to see?
I know following, it was an interesting recommendation from the Royal Commission in Victoria, because that's Victoria specific, but was actually one of the recommendations was for the chief psychiatrist to work with the professional bodies of psychology, general practice, and social work to set a family violence agenda for their respective professions. And I don't know how far that work has gone, but we at the time found out that the Australian Association for Social Workers, forgive me if I got the title wrong, had already commenced at that time, and that's about 2 years ago now, in actually getting family violence embedded in their social work training across the nation. So there is some work afoot, but
and
that's
the
not training.
The College of GPs have done the most work.
Has done it for 25 years. The college have done it, for a much longer time already, but this was new. I don't know that that's about, that might be different to training and ongoing professional development, but I know there was some work done in College of GPs, of course. was.
And it still needs to happen in the psychology profession, and particularly in terms of what is offered at university level. I've been banging on about it for a long time, a bit like
coming back to that talk just in time, the collaborative response. That is, we have to wrap up. I'm getting the nod from Rachel. So we have come to the end of today. I'd really like to say thank you very much, Fiona. Your experience and your expertise in communicating your experience has just been incredibly insightful and a great assistance, and really informed the presentation of both of Kelsey, Sabine and Carmel. So thank you all very much. That's the end, and I'd also like to say thanks to Maeve. It's been a great collaborative effort to talk today. It is a really complicated and very complex topic. We've really only touched the very edges of that, but we have the campaign that Kelsey has been talking about as something to take away. And also I'm going to share with you the coercive control policy brief, that in addition to the other papers that have been referred to today, and that's a policy brief that ANROWS published on Friday. I would also like to remind the audience that the ANROWS National Research Conference is from the 1st to the 5th of March. This is an fully online symposium as a result of the situation we found ourselves in with COVID. But you will be able to hear Kelsey speak again to how do we transform health systems to address sexual violence, domestic abuse and family violence. So there will be aspects of the conversation that we've started today if you'd like to take that further in the conference. And you can visit the ANROWS website for more information about that. Again, I'd like to thank you all very much, the panel. You've been incredibly informative and very generous in giving up your time today. Thanks, everybody.
Thanks for having me.
Thank you.
Thanks, everyone.
Thanks.